I'm delighted today to welcome John O'Dwyer and Jim Dowdall, John from the VHI and Jim from Irish Life Health. We did invite Donald Clancy from Leia Healthcare, who unfortunately couldn't make it. He's out of the country. A very brief background to the two gentlemen. John O'Dwyer started out in the VHI. He started his career in the VHI before leaving, together with a few colleagues at the time, to set up Bupa Ireland, which was the first real competition to the VHI. I often wondered, as John sitting in his office today, wondering why he did that. But anyway, he left Bupa Ireland, joined France First, spent some time abroad, and is now back in Ireland, and as you know, is the CEO of the VHI. Jim started out in healthcare back in 2004, and he together with a few colleagues set up Vivas, and you may recall Vivas was then acquired by Hibernian, who then sold it on to Aviva, and now it's within the Irish Life stable. And as you know, Aviva and Glow have been merged, and it's now called Irish Life Health. Just very quickly before I hand over, we're going to have about 10 minutes each from each of the panelists, and after that we'll have some questions and answers. Just before I hand over to John, while he's making his way up, I often think, and we often overlook it, that the private hospitals and the health insurers is very much a partnership. I know it doesn't feel like that too often, but without each other we wouldn't exist. And it's you know, there are over 2.2 million people with private health insurance. The insurers are facing the same problems as the country generally is: an aging population. They've got an aging membership, and traditionally a lot of the demand from the members of the health insurers has been provided by the public health system, and perhaps that's all about to change. We'll soon find out. Anyway, John, over to you.
Good afternoon. I'm really pleased to have an opportunity to participate in your conference, and let's make sure I have a clicker here. Yes. Here it is here. Oh, okay. So what I'd like to do over the next few minutes is to just give you a little flavour of our health insurance market. But in particular, I'd like to talk about some of the challenges facing the health insurance industry, and look at some solutions or what other people in particular outside of Ireland are coming up with to address some of the problems that we face. So just one slide here, a little bit on the health insurance market. As James said, we have nearly 2.2 million people have private health insurance, and that's 46% of the population. And the premium that the average person pays is just under €1,200. So, you know, some of the, when we look, we paid €2 billion in claims, and that was the 2015 total market payout. I suppose when we look, and we draw a comparison here, when we look at motor insurance, for example, my understanding that the total payout in claims in motor insurance, for example, is 1.2 billion. So you can see it's dramatically more. So when we look at market trends in our market here, up to 2015, you know, we saw the market declining year on year. But that has stopped in 2015, I'm glad to say, and we've seen small increases in the market over the last couple of years. That's helped clearly by the economy and the growth in employment, but also helped by a number of initiatives that the government took in stimulating the market with lifetime community rating, and also discounts for young adults to try and encourage them in and stay in the market. So we have challenges in the market, which I'll come to, on ageing, And we also have increased commoditization in the products. Well articulated earlier, and is the challenges we have, and in particular acute at the moment, in how we're managing the public hospital charges. We have the benefit downgrade. It's a phenomenon in Ireland, but it's an international challenge as well for lots of health insurers. So it's a big market and a challenging market. But when we look at some of the real challenges facing our market, there's probably two big things. One is the demographics, and two then is the incidence of chronic disease. If I just take demographics first, and there's lots of numbers we could take here, but if I just look at what's happened, say, over the last 20 years, we've grown as a country. The number of over 65s have grown from 400 odd thousand to 600 odd thousand. And what we have is that 200,000 growth in over 65s happened in a 20-year time span. So the forecasts show that we're going to grow by well over 200,000 over the next 10 years, not 20 years. So then when we look at those demographics and we plug them in to what's happening, in particular in chronic diseases, is that 62% of people over 65 have one or more chronic disease. We're also seeing that the diagnosis of cancer, 30,000 new diagnoses a year. When we look at the VHI payout, the number one payout is on cancer claims. So very challenging demographics and very challenging chronic disease. So when we look at this and we say, okay, what does that mean for claims costs? So when we in VHI, we look at our strategies and plans for the next 10 years, and we look at the claims costs. In 2015, the industry paid 1.9 billion in claims. And we look over the next 10 years, with some of those demographics in particular, that's going to rise to 3.4 billion. Now, what happened in the last maybe 10 or 15 years, in particular where there was significant claims growth, is the growth in medical costs or medical inflation was there or thereabouts matched with wage increases. And over the next 10 years, we see clearly claims costs are going to rise far quicker than disposable income. And that's going to give huge challenges to the private health insurance market. So when we've all of us and all of our competitors, talk about what we call the affordability spiral here, okay? So we have market aging, we've rising healthcare costs, and when the healthcare costs rise, okay, young members in particular exit the market, but downgrades also happen. And what we have here is an affordability spiral. So when you have a community rated market that's very much depending on a mix of young and old, healthy and sick, and you get some of the dynamics wrong, you have this affordability spiral, which I suggest is not good for the whole private market. So what we have seen, and what in particular I have observed with other countries and what they're trying to do, is that there is standardized clinical processes and technology. There is a significant investment in digital health, and with lot better health infrastructure. In particular, not everybody needs to go in to acute hospitals. There is now subacute hospitals or daycare hospitals and step-down facilities, and we need a whole integrated care model. I think it was Jack Chambers talk earlier about the whole generalist model, and we're seeing this particularly in the UK and some parts of the States really taking hold and delivering huge benefits. And also from an insurer and a provider perspective here, quality and outcomes, the measurement of them and ultimately the rewarding on that basis is what we're seeing happening throughout the world. In summary, I think here that we, and I use the royal we, I think we've made a great start if we recognize that what sustained us in the last 10 or 20 years will not sustain us going forward. The challenge is here, as one of my colleagues put it, as a country we're aging on speed, okay, and that's going to bring lots of healthcare challenges. We have to work together, find new innovative solutions to make sure that they are affordable. If people cannot afford it, I think we're all challenged, and we must work together to find solutions to meet these challenges that clearly will happen over the next 10 or 15 years. Thank you.
Thank you, John. Very interesting. I'd like now to welcome Jim Dowdall, who I'm sure will share some of the same sentiments as John. Jim, very welcome.
Good afternoon. I think I'm delighted to say that many of the points that I'm going to make here are quite consistent with John's, which is good to see us all on the same page. I think this conference is really important for us because it's rare that this group of stakeholders get together in the same room, yet we all have such an important role to play in the delivery of a quality health system. And I'm delighted to have the opportunity to share my thoughts. So as James said, about 10 minutes, so I'll just move straight through them. But before I get into the main points, I think it's important that a consideration that we should all have is the payer of the overall health system. So everything we're talking about today, the private system and the public system, is paid for by exactly the same people, which is a subset of the adult population in Ireland. And we need to recognise that. And it's not an area that generally gets picked up. It didn't get a huge amount of reference in the conversation so far today. But if we put a sense around what this means, the public system we know costs about €14 billion a year at the moment. So let's apportion that 14 billion across 1.5 million taxpayers, not including those who are exempt from paying tax. And then let's include in pensioners and round the total in terms of the population that is paying for the cost of the system up to about 2 million people. That means that subset of the population are paying about €7,000 a year to fund the public health system. And if we think about the future demand on the public system going forward, and we just look at a short 10-year horizon, the OECD forecasts that our cost for the health system will increase by 50% in just over 10 years. Now, we seriously hope that they have over-egged that one and it's way off the mark, because that's a 7 billion incremental spend on top of the 14 that we already spend today. So assume that they're wrong and it's just a 20% increase. So that means in 10 years' time, the cost of the public system will have increased by an additional €3 billion a year. And that'll be funded by the same group of people. So it means their tax contribution will have increased by about €1,500 each per year to fund that increased cost. And, you know, considering the ageing population that was referred to earlier by Jim and that John referred to and so on, this is not an unreal scenario that that level of increase will come through. And we know that just to provide the bed nights for the over 65 population that is increasing year on year in the next 10 years will require the equivalent of 3 additional Beaumont hospitals in terms of bed capacity. And I don't think that is included in anybody's plans at the moment. So now if we talk about the private system, just to round out the picture on the burden that we're placing on a small subset of the population, it's primarily paid for by people who have health insurance, the same people who already fund fully the public health system. And the amount paying for an adult when you include in children's premiums is over €1,500 a year for each of those. And if we think about how that has increased since 2003, when the industry paid about €970 million in terms of claims costs, and as John indicated, that went to over €2 billion in 2016. That's about a 140% increase in the cost of claims paid for private health insurance customers. And there has been a corresponding percentage increase in the cost of premiums that are being paid. But yet, if we have a look at the average industrial wage over the same period, it's increased by about 30%. So there's a very significant difference in terms of the burden that has been placed and the affordability challenge that people face. So let's assume going forward that just to handle the ageing population that we talk about, that the private health insurance claims costs increase by about, let's say, give or take 4% a year, which will be a really positive outturn. In 10 years' time, that'll be an additional €1 billion a year in terms of medical claims, moving it up to the same number that John talked about, which is about €3.5 billion a year. And if we combine the implications of that for people who are paying for health insurance is the adult premium will have increased by about €600 on top of what they're already paying today, that 1,500 that I referred to. So combine both of those and we'll see in 10 years' time that the same subset of the population who are funding both the public and private system will have a demand placed on them for about €11,000 each per year. And that is very significant. So no surprise today when my focus really to start when we talk about what is expected and what we will need to adapt, how we'll need to adapt going forward will be on the cost of the system. So the first element really is about the affordability challenge, and that is always going to be a serious issue for people who are funding the private healthcare system. And if we look at the areas that consume private health insurance premiums, about 95% of that is taken up by costs that go to consultants, to private hospitals and to public hospitals, with the remainder going on primary care benefits. And if we take the first two groups, the consultants and the private hospitals, there is a pressure always for increasing costs across the board. And we can always appreciate some of the reasons for that ask. However, the challenge is that for each individual party requesting an increase, it makes sense. But when you put the sum of those increases together and consider that those costs are falling back on the same individuals, then it is a real challenge. So if health insurers are being asked to increase the rates that we pay into the medical system, then we need to be very clear that we're determined to work together to create opportunities to take equivalent cost out somewhere else. And we need to make sure that the costs associated with technologies are justified. We need to ask real hard questions about health technology assessments. Do these technologies really deliver value? And does every hospital need to have them, particularly when you consider the level of underutilization of some of these technologies that exists? And do all new technologies really need to be more expensive than the technologies that they're replacing? And this is the single biggest mindset change that we need to consider going forward. Consultants and private hospital managers need to work in meaningful partnerships with health insurers to make sure that we can keep developing and improving care models and treatment models, but while also being fully committed to making sure that we can sustain the costs that are being imposed on a very small number of people and ensuring that we get value from that level of spend. And if I move on and talk about the third constituent there, which is the public system, and still sticking on the cost and affordability point, and I think this is where the single biggest gap exists in terms of the need for meaningful partnerships, and it is a critical area that we must adapt our thinking in going forward. And I particularly want to use the example that's been imposed, of the cost being imposed on the public system on the one group of people who are funding both health systems. And I think we're all familiar now with the fact that in 2014 the rules of the game changed. And what happened then was that we moved from a model where people who had health insurance paid additional fees when they got additional services to a model today where people who are using the public health system and happen to have health insurance are being charged additional fees for nothing. And that is a big challenge. And before this change was implemented, about €450 million a year was paid into the public hospital system. But when it changed, then it created an opportunity for the HSE to find every opportunity to extract more and more from this group, with an additional charge of about €200 million a year now being extracted from health insurance customers. And really need to be clear on this one. Health insurance companies or health insurance customers have no problem whatsoever paying for additional services when they get more than that which they're already entitled to. But this imposed change that took place in 2014 is really just short-sighted opportunism, and it is simply not sustainable. It is unfair, it is double taxation, and it is diverting €200 million of spend away from medical treatments where we could be delivering real value. So in terms of adapting going forward, we need to start by putting some integrity back into the system and being honest about what patients should be charged for. And we should commit to ensuring that funds are used for what the patient or what the customer actually intends them to be used for, providing medical care. And €200 million is a really significant amount of money. For example, it could deliver 10,000 scopes, and it could clear every person that's on an orthopaedic waiting list and provide a hip replacement for each and every one of them. It's a very significant amount of money. It could provide very meaningful well-being benefits for the people who are paying that money, or it could reduce the cost of their health insurance, and that is a very significant challenge that John alluded to earlier on. And a word of warning, I think, that we all need to consider in this room, that the funding from people, the same people who are funding both the public and the private system, is not as elastic as people seem to think. And that seems to be one of the biggest problems we have with our health system. When it comes to the costs, it always seems to be somebody else's problem. And that's a mindset change that we need to tackle, that we have to commit to changing this model. So The next area that I want to focus on relates to quality of service and value for money. And this needs to be a key focus area going forward. And the model needs to be one that changes, where we pay for outcomes and not procedures. And internationally, health insurers are moving away from traditional fee-for-service models and towards reimbursement for value and quality outcomes. And we need to do the same in Ireland. So from our perspective as a health insurance provider, measures will become the norm. Lengths of stay, readmissions, infection control, treatment settings, they are all measures that we will assess the quality of the contribution that is being provided by our partners. Excellence in delivery will need to be validated and demonstrated, and this will become a differentiator, at least for private hospitals. It'll become part of the contractual relationship that we have between health insurers and medical providers. And different relationships will be established based on such measures, because our customers will ask for that and will require comfort that they are getting treated in settings that achieve internationally recognized quality standards. Health insurers will share the outcome information with customers, and we will provide comparisons against other facilities, including those facilities in other geographies. And all hospitals covered will need to be independently assessed, including HSC facilities. And we can expect that hospitals will start to be excluded if they don't meet those standards. And health insurers will start to provide directional care. And the last area that I just want to focus on that will require us to adapt our model going forward relates to positive outcomes that result from the latest cycle in the technology industry. And I'm talking about the cloud and internet computing revolution that's taken place. And we can see it transforming other industries, and we would be naive to think that it is not going to impact ours. And these are opportunities that really excite us. So location, geographies, access, they will no longer be the barriers that they once were. So we've already seen developments in small ways in this regard. For example, digital doctor services, where you can get video consultation with doctors on a 24-hour basis in a follow-the-sun type model. That will develop and that will extend. It'll develop into digital clinics. It'll develop into access to consultants across other geographies, not just in Ireland. And it will involve access to other medical specialists, and international second opinions will become a norm. And that is something that can be welcomed. So we will be able to leverage capabilities and skills that don't necessarily exist in Ireland, or to complement the ones that do. And the last area in relation to innovation is about providing new and innovative solutions to a critical stakeholder in the group that we haven't referred to at all today, and that is corporate clients in Ireland. And you may not be aware that corporate clients in Ireland contribute about €700 million a year through health insurance premiums to funding the health system that we have here. And their mindset is changing. They no longer just want to be getting access to sickness cover. They want health and well-being benefits, and they want to direct their spend into programs that add value for their employees. They are less concerned about an overall Irish health system. They are very concerned about the health and well-being of their particular staff. And they're very energised and frustrated about the increase in cost of healthcare cover, as they're aware they're seeing little benefit for their key stakeholder group. And this focus on health and well-being is also consistent with the thinking of millennials and the younger population, who are really important contributors to a community-rated system. They want to see more value, and they want to see more benefits. And this will be a paradigm shift for us, because we will move significantly over the next 10 years from a focus very much on sickness cover to health and well-being cover, where our customers, patients, will be able to recognise a very strong contribution to their particular requirements. However, there is a challenge that will come with this, that this will redirect funds away from hospitals, and in itself will start to place more pressure on the sustainability of a community-rated system. So we need to find ways to mitigate against that, and to continuously adapt our offerings and our product, so that we're providing services that people want to have, and they will stay committed to being a participant in a community-rated health insurance system. So in conclusion, we are really aware that there is a very poor track record that suggests of stakeholders in the health system working in a coordinated and a collaborative way. And this has to change. And the centre of our thinking now needs to be very much the customer or the payer, who need to recognise they're getting value from their significant contribution to our overall health system. And we know they're paying very, very handsomely for that. And this, I suggest, is where it is going to be really important for policymakers to adapt. We need to involve all stakeholders in the design of the new solution that we're going to put in place. And we need to bring medical providers, private medical providers and private health insurers to the table in a meaningful way, so that we can collaborate in designing a system that can work. Thank you.